Okay, wonderful. Thank you. I'm very happy to be here today to introduce our speaker, Dr. Douglas Levy, who's going to be speaking on an emerging and increasingly important topic in the issue of tobacco prevention and control. Over the past several decades, we've made a lot of great progress in terms of reducing cigarette smoking. And the most recent data were actually released last month at the federal level from the National Health Interview Survey, show that we're down to 15.1% in terms of adult cigarette smoking rates. And that's exponentially lower than the 40% plus rates that we saw back in the 1960s before the first Surgeon General's report on tobacco use was released. However, despite the declines in cigarette smoking, things are complicated by the fact that there's an emerging tobacco landscape, and there's new tobacco products that are entering the market, including electronic cigarettes and other forms of combustible tobacco products such as hookah. And also, correspondingly, we've also seen great reductions in secondhand smoke exposure. And this has been largely attributed to the implementation of comprehensive smoke-free policies in indoor public places, such as work sites, restaurants, and bars. This momentum really galvanized at the local level in the 90s, and then in 2002, Delaware became the first state to have a comprehensive smoke-free law. And we've seen great progress over time. Most recently, California closed some loopholes in their statewide laws, so we now have 26 states in the District of Columbia with comprehensive smoke-free laws in public areas. But in turn, the implementation of these comprehensive policies in public areas has left private settings is an increasingly important source of exposure, particularly for children. And we know that there's still 58 million Americans that are exposed to secondhand smoke in different environments, and key groups are particularly likely to be exposed, including children, non-Hispanic Black persons, those living in poverty, and renters. And the renters is really a key demographic because it represents this issue of multi-unit housing, and that people can still implement a smoke-free rule in their own home, but even if they do so, if their building isn't smoke-free, they can still experience secondhand smoke exposure from other areas in the building, such as units where smoking is occurring, as well as common areas and in shared areas. And so really, irrespective of the environment that we're talking about, there's no risk-free level of secondhand smoke. And in order to fully protect people, you have to eliminate the source. And so the most effective way to do that is to implement a smoke-free policy. And so there's really been great momentum over time, particularly in recent years, to implement smoke-free policies in multi-unit housing. And most recently, the U.S. Department of Housing and Urban Development announced a proposed rule to do that, to protect the 2 million public housing residents in this country from exposure to secondhand smoke. And so we've had a lot of great science and data that has helped inform this over time, but there's still a dearth of evidence, particularly on the evaluation of the impact of these policies and what the impact is in terms of compliance and enforcement, but also reductions in exposure and what the impact is in terms of smoking behaviors and tobacco use, both before, during, and after these policies. And so that really, leaves the door open to our speaker today, which is really helping to fill that evidence gap. Boston Housing Authority was one of the vanguard groups working on smoke-free public housing, and it's ideal that they're moving forward with some data to help evaluate the policy that they've put in place to help inform the adoption of similar policies moving forward across the country. And so our speaker today, who's going to talk on the evaluation efforts for the Boston Public Housing Smoke-Free Policy is Dr. Douglas Levy. And he's an assistant professor of medicine at Harvard Medical School and Massachusetts General Hospital, where he's a faculty member at the Mongan Institute Health Policy Center and Tobacco Research and Treatment Center. He has his PhD in health policy from Harvard University, and he completed a postdoctoral fellowship in health services research at Harvard prior to joining Massachusetts General. His research interests have focused on studying how policies in the spheres of public health, healthcare, and finance and health services can really improve prevention and population health. And one key component of this work is the study of policies to reduce the harms of tobacco use. And he's been studying this pertinent issue of smoke-free policies in public housing in and around Boston since 2010. And so without further ado, I will turn it over to our speaker, Dr. Douglas Levy.
Thank you, Brian. Dr. Levy?
Hello?
Hello, Dr. Levy.
Can you hear me?
Yes, we can. You're free
Wonderful.
to go.
Great. So I want to thank Brian for that wonderful introduction, and also Phil for inviting me to speak here. As indicated, I'm going to talk a bit about what Boston's experience has been with smoke-free public housing. So if we could move to the next slide. I think Brian went over most of this, but as we know, secondhand smoke exposure adversely affects health. It's a trigger for asthma, causes cardiovascular disease, stroke and lung cancer. The Surgeon General's report has indicated that there's no safe level of exposure, and as Brian indicated, secondhand smoke exposure is more common and it exists at higher levels in multi-unit housing than in detached housing, and that's especially true for low-income residents. Obviously low-income residents are more likely to be living in multi-unit housing, but they're also more likely to be smokers, and the two of those factors together makes this particularly pertinent in that setting. So next slide, please. We can actually advance through this slide, I think, to the following slide, since this will be largely familiar to everybody who's on the call. So beginning in 2009, HUD was encouraging public housing authorities to adopt smoke-free policies, and then last November, Secretary Castro announced a proposed rule that was going to institute smoke-free policies in all federally funded public housing. So next slide, please. And as Brian indicated, smoke-free policies, clean indoor air policies, have been sort of steadily on the rise for the last 15 to 20 years, to the point where now about 30 states have one or more smoke-free rules in restaurants, bars, or workplaces. But if we look at the bottom line on the graph here, this is the number of housing authorities, local housing authorities around the country that have adopted smoke-free policies out of a total of about 3,000 housing authorities. And so this is clearly substantially behind where we are with other arenas of clean indoor air regulation. It's not entirely surprising. This is, banning smoking in public places is at this point fairly uncontroversial, but taking these rules into into people's homes and into people's private spaces is obviously a significant expansion of this sort of policy, and obviously there are good reasons to consider that in terms of how smoke travels through buildings. I think something which puts this at kind of the cutting edge of clean indoor air regulation. So let's move to the next slide. So back in 2010, Mayor Menino in Boston announced that the Boston Housing Authority was going to adopt a smoke-free policy, and at that point in time, it was planned to go into effect in 2014. So next slide, please. And over the course of this talk, what I'm going to do is I'll talk about Boston as a smoke-free public housing authority lab and go over some of the pilot work that we did initially before the smoke-free policy went into effect. And then I'll spend some time talking about what we're calling the fresh air study, which was an evaluation of Boston's policy and what its effects were. And then we'll also talk a little bit about some follow-on work that we did, lessons that we've learned, and obviously there's a number of questions that are still left unanswered. So next slide, please. So this is just for orientation purposes. This is the city of Boston with Boston Harbor and Massachusetts Bay on the right-hand side there. At the top of the map is Cambridge, Massachusetts, which we'll talk a bit about as well later on. So next slide, please. And this is a map of where the public housing developments are in the city of Boston. So they're pretty well distributed throughout the city. The BHA houses about 10% of city residents. The population of the city is, I think, about 660,000 at this point. Now that includes public housing broadly defined, but about 22,000 live in BHA-owned and operated buildings. That consists of about 11,000 apartments spread around the city. Those are in 64 different housing developments, which are the dots here on the map. 37 of those housing developments are specifically are funded for elderly and disabled residents, and that's about a quarter of this population. and 27 of the developments are for families, and that's about 75% of the residents. The developments are range from high-rise buildings to low-rise garden apartments. Some are single buildings, some are dozens of buildings. Next slide, please. The BHA residents are a very diverse population. About 16% are white, and if you know the city of Boston, that's this is a very highly minority concentrated group of residents. About a third are Black, African American, 42% are Hispanic or Latino, 10% Asian. And English is the preferred language for 44% of residents, and 28% have Spanish as their preferred language, and 5% Mandarin or Cantonese. And those statistics are based on the fact that the housing authorities are required to have printed materials for any language population that exceeds 5%, I believe. But you can see here that that does not add up to 100%, and there are a number of other languages that round out that total. All right, next slide, please. About a third of the population in the BHA are children under the age of 18. About half are adults between 18 and 61 years old, and 20% are 62 years or older. The smoking statistic I have here is from the Behavioral Risk Factor Surveillance Survey, which was done by the city in 2009. So these numbers are a bit outdated. 19% of the BHA residents were smokers, and at that time, that compared to about 14% statewide. So obviously a significantly higher smoking rate in this population than across the state, and that at that point in time compared to about 20% smoking rate nationally. Next slide, please. So just a bit of history on where the policy came from. Back in 2009, there were a few units in the BHA that went smoke-free voluntarily. There was one building which had an entryway that serviced 6 apartments, and there were many entryways in this building, but one entryway, the residents there all mutually decided that they would adhere to a smoke-free policy of their own devising. And then there was also at that time a development which had been undergoing renovation, and when it was reopened to residents, the residents agreed that the entire development would be smoke-free, and that was spearheaded by a grandmother whose grandson suffered from asthma and was finding himself in the emergency room due to secondhand smoke exposure. So this seed of smoke-free policies in Boston, at least, was very much resident initiated. And based on that, the Housing Authority established a smoke-free working group. And that group was put together to think about the feasibility of the policy, what the specifics of the policy might be, getting feedback from residents and educating them about what a policy might look like. So as I mentioned, the mayor announced that the smoke-free policy would be in place by 2014, but it was ultimately actually implemented on September 30th of 2012, so well ahead of that schedule. And the BHA was the largest public housing authority in the U.S. at the time to institute a comprehensive smoke-free policy. Next slide. So just some details on what the policy stated, so that there would be no smoking anywhere in BHA buildings, including apartments or within specified distance of the building. And I think that was ultimately 15 to 25 feet. So it had always been the case that you weren't allowed to smoke in common areas, so the expansion of this rule then brought it into people's living spaces. The rule applies to residents, visitors, and employees. And violations of the policy are considered lease violations. So those can result in fines of up to $250 for residents. And in this population, that's a very steep fine. If there are repeat violations, it can ultimately lead to eviction. And the Housing Authority has been very clear throughout that this is not a ban on smokers, it's just a ban on smoking within people's apartments. Next slide, please. So as the policy was developed and then implemented, the process for implementation was meetings were held at every one of the 64 developments around the Housing Authority, and the meetings were there to tell residents what the policy was, what it wasn't, answer questions. at the time, smoking cessation treatment were offered to any residents who were smokers who were interested, and that was in the form of cessation classes, which were led by personnel from the Boston Public Health Commission, the Department of Public Health for the city. Each of the building managers was notified of the policy, obviously, and trained about what the policy meant. They had some discretion at the time to establish development-specific smoking rules. So would there be a dedicated smoking area on the development, or determining where the no smoking perimeters around the buildings would be. I think ultimately the policy dictated a specific distance. That's complicated by the fact that the BHA is obviously in a dense urban environment, and sometimes that 15 to 25 foot perimeter around a building extends beyond the property that the BHA actually controls. So in addition to that, signage was established on all the properties indicating that smoking was not allowed. And each head of household is required to meet with their building manager on an annual basis to renew their lease. And at that point in time, and that's a rolling process, but when each head of household had their meeting, they were asked to sign a document indicating that they were had been informed of and were aware of the impending smoke-free policy. One thing which wasn't really very explicitly discussed at the outset was what shape enforcement was going to take. All right, next slide, please. There are a number of reasons why the policy might not be expected to reduce secondhand smoke exposure among residents. So obviously, first and foremost, if there's non-compliance or if the policies are poorly enforced, then they're not going to achieve their desired ends. There might be new sources of exposure as locations where smoking is permitted shift. So one scenario that we envisioned was, prior to the policy, you might have smokers in isolated locations around a building or a housing development in their specific apartments. But then if they're all forced to be outside, they might be congregating in a specific spot. And if that's a spot that has a lot of traffic amongst non-smokers, that could actually increase non-smokers' exposures to secondhand smoke. And obviously, if the perimeters are not adequately enforced and people are outdoors and outside other folks' windows, then smoke can be entering the building through those means. All right, next slide, please. So prior to the policy going into effect, we did a number of pilot studies, 3 that I'll talk about here. One where we did cotinine testing of BHA residents, and I'll explain that further. We did some environmental monitoring of indoor air quality in public spaces on BHA properties, and we did some comparison of indoor air quality in smoking allowed versus smoke-free units. Next slide. So the first pilot study we did was in the winter of 2011, obviously before the policy went into effect. We did this at 2 BHA locations, and we got 61 volunteer subjects who were all non-smokers, both adults and children. They got $15 for participating in our study. And we collected a saliva cotinine sample. So cotinine is a sort of gold standard and inexpensively analyzable metabolite of nicotine, so a very specific measure of tobacco exposure. And then we also assessed self-reported tobacco exposure. So next slide, please. And what we found was using a commercial test that had a lower limit of detection of 0.15 nanograms per milliliter, that 88% of the residents in our sample had detectable nicotine. So if we think about that in the context of no safe level of exposure to secondhand smoke, that suggests that an enormous proportion of this population, or at least this sample, has secondhand smoke exposure. And in comparison, when we look at data from the National Health and Nutrition Examination Study run by the CDC and the NCHS, they're using a 0.015 nanogram per milliliter lower limit of detection test for cotinine. They're measuring serum cotinine. We were measuring saliva cotinine. So there are obviously some differences there, but they are very highly correlated. They found about 40% of adults at that same time period in all housing had detectable cotinine. 36% of children in detached homes had detectable cotinine, and 56% of children in multi-unit housing had detectable cotinine. So with our test, which is 10 times less sensitive than the NHANES test, we were finding substantially higher proportions of residents who were exposed. We also looked at the geometric mean level of cotinines, and we found 0.52 nanograms per milliliter. And in comparison to the national numbers from the NHANES, that was 5 to 10 times higher than the levels detected there. So really an indication that there might be a serious issue of secondhand smoke exposure in this population relative to others. Next slide. And then we also looked at the cotinine levels as a function of people's responses to our survey questions. So in the first two questions there, asking about whether there were smokers in the household or whether there was a no smoking rule. In households where there were smokers or where there was where smoking was allowed, there were higher levels of cotinine than in other households. That's not surprising. We asked about perceived smoking prevalence in the developments, and there was no relationship between cotinine and that measure. And then interestingly, we asked about people who smelled smoke within their homes or in hallways, and the folks who said yes actually had lower cotinine levels than the folks who said no. And our interpretation of that is likely that folks who are sort of consistently exposed to secondhand smoke become desensitized to it and stop noticing, whereas maybe people who are most put off by tobacco smoke might be more likely to notice it and avoid it. So definitely calls into question sort of the utility of some self-report measures in this context. Okay, next slide, please. So the second study, we were comparing levels of tobacco smoke pollution in common areas of 6 BHA properties, again, prior to the policy rollout. We looked across different building types. So we had family housing buildings and elderly and disabled housing buildings. We had the 2 sites where smoking was not allowed, as well as 4 sites where smoking was allowed. And we took measurements in the wintertime and in the summertime. And in Boston, in the wintertime, buildings tend to be sealed up, which we expected to reduce air exchange and concentrate secondhand smoke levels in the buildings, whereas in summer, the buildings are much more wide open and have more air exchange than we expected that there would be lower levels of tobacco smoke pollution in that time period. All right, next slide, please. So the measures that we took were done over 7 days in each period. We took measures of airborne nicotine. You can see in the picture here an example of what these monitors look like. They're plastic cassettes that have a piece of filter paper on there that's coated with a particular compound. We didn't actually hang this on people. We hung this on available structures within the buildings. These are good for assessing tobacco exposure, obviously, because nicotine is specific to tobacco. They need to be in place for a period of time in order to be able to detect secondhand smoke or passive smoking rather than active smoking. Then we also took an assessment of particulate matter, PM2.5 in particular, using side packs. So we had this active real-time monitoring. We had fewer measurements with PM2.5 than with the nicotine, just because the monitors are more expensive. And we also used gravimetric measurement for the PM2.5. This gives us, the real-time gives us, so the side packs give us the advantage of the real-time monitoring, but PM2.5 is not specific to tobacco. So next slide, please. Here are our principal findings. I'd like to call your attention to the fact that the y-axes here are on the logarithmic scale, so the differences are larger as you go up the scale. And what we found was, if we first look at the 2 sets of bars on the left, where we're looking at nicotine levels, that in the elderly and disabled housing, which is the lightest color there were the highest levels. All of those had smoking allowed. The family developments where smoking was allowed were sort of at a middle level. That's the yellowish bar in the center. And then in family housing, where there were the voluntary smoking bans, we saw the lowest levels of nicotine there in the wintertime. However, then in the summertime, we did not see that same pattern of differences in airborne tobacco smoke levels. It was fairly flat with a slightly higher level for the individual smoking allowed family sites. When we look at the PM 2.5, we see largely the same picture, just on a slightly different scale. Again, distinctions between elderly and disabled smoking allowed housing in the winter versus individual smoking allowed and individual family smoking allowed and family smoke-free housing. And again, the differences were there in the wintertime, but not in the summer. So, take-home messages here are that it appears that there's an association between smoke-free policies and lower levels of tobacco smoke pollution in the air. So that's a positive thing in support of these policies. And then secondarily, it looks like this is a bigger deal in buildings in the wintertime than in the summer. All right, next slide, please. So our third pilot study was done with colleagues at the Boston Public Health Commission, and in this study we recruited BHA residents, 15 households with smokers and 17 households with no smokers from 5 different housing developments. Some of the developments were these smoke-free pre-policies, others transitioned during the measurement, but we accounted for sort of when smoking was allowed and when wasn't. And we measured air nicotine, PM 2.5, and self-reported exposures. I'm just going to focus on some of the PM 2.5 findings here. And these measurements were done both in units and in hallways. Next slide, please. First finding is that PM 2.5 was lower in the smoke-free sites than it was in the smoking-allowed sites. So that's, again, in support of the effectiveness of these policies. And that was true for households with smokers as well as households with no smokers. And these were statistically significant differences. Next slide, please. And then this is one of my sort of favorite figures from this whole body of work. Here we're looking at side pack measurements of PM 2.5 in 2 adjacent apartments. So one apartment was occupied by a smoker who was a participant in the study and who recorded when smoking was taking place in the apartment. So this is over a roughly 4-hour period, and the dark line there is the levels of PM 2.5 in that apartment. Then at the same time, in an adjacent apartment, which was unoccupied, we had an additional side pack. And so we were able to measure PM 2.5 in that adjacent apartment over the same time period. Note that the scales are different here, so that the levels that are in the adjacent smoke-free apartment are substantially lower, but we magnified it here for ease of interpretation. And at 4 p.m., approximately, a smoking event takes place. The resident lights up a cigarette. You see a big spike within the smoker's apartment, and then slowly over the next hour or so, the levels of PM 2.5 are elevated within the adjacent apartment. And then again, at 6:15-ish and close to 7, there were 2 more cigarettes. The levels of PM 2.5 again go up in the smoker's unit and again go up in the adjacent unit. And so this is kind of a really nice illustration of how the behavior of a smoking resident is going to have an impact on their non-smoking neighbors. Next slide, please. Thanks. So that brings us to the Fresh Air study. So this is a 3-year study which was funded by the NIH to assess Boston's smoke-free policy specifically. So next slide, please. This is what our study design looked like. We did measurements in Boston in the summer and fall of 2012, so just prior to the September 30 institution of the smoke-free policy in Boston, and then we did measurements again approximately a year later when Boston had gone smoke-free. And as a control group, we recruited residents from the Cambridge Housing Authority just across the Charles River. Very similar housing stock, relatively similar resident populations, and over this time period, smoking was allowed in all Cambridge Housing Authority buildings, so or in the apartments there. We did measurements using surveys. We again measured saliva cotinine, this time with a more sensitive test. Again, measured air nicotine and PM2.5. Next slide, please. So the first aim of the study was to see, does the smoke-free policy reduce secondhand smoke exposure and tobacco smoke pollution, so in residence and in apartments. So we measured the saliva cotinine, in-unit airborne nicotine, and self-reports. For our second aim, we wanted to see what the sources were of tobacco smoke pollution in these two housing authorities before and after the policy. Did the institution of the policy reduce smoking levels in some areas of buildings and increase it in others? And then lastly, we wanted to use our survey to ask residents what their knowledge and attitudes and beliefs were about about secondhand smoke and about the smoke-free policy. Next slide, please. The folks who were included in this study were residents of family developments. We restricted it to family developments basically for resource reasons, budgetary reasons. We included anybody who was an English or Spanish speaker. Households had to be households where no one was a smoker. And the rationale there was that the purpose of the policy is to protect non-smokers from environmental tobacco smoke or from tobacco smoke pollution from their neighbors, and so that's where we wanted to see if there was an effect. We excluded those who had other uses of nicotine. In particular, we were thinking about nicotine patches and nicotine gum for folks who were trying to quit smoking. We didn't ask specifically about e-cigarettes at the time. Back in 2012, this wasn't as prominent an issue as it is now, so I think it's probably unlikely that there was much of that going on, if any. So we were ultimately able to enroll 192 households in the BHA and 95 households in Cambridge. One resident per household was a participant in the study, and we were able to follow up with 80% of those at our one-year follow-up. Next slide, please. So our measures were self-report, or exposure measures in particular. So we had survey items asking folks about where around their housing developments or elsewhere in their lives they might be exposed to smoke, tobacco smoke, what the circumstances were, and in some cases what the duration of that exposure might have been. We put the nicotine monitors in place in all the participants' apartments. Those were deployed at the time that we did our interviews, and they were retrieved about 7 days later. Folks also had a checklist of smoking, air conditioning, and window use so that we could examine those as potential confounders of the nicotine measurements. And then we also took saliva samples at the time of the interview, and this time our test had a sensitivity, a lower limit of detection of 0.02 nanograms per milliliter. Next slide, please. So to the results. Next slide. These will reveal themselves as we go a little bit. There's some animations built into the slides. We'll see how this works out over the phone. So you can see here that there was a reduction in self-reported smoke exposure in the BHA from about 32-33% at baseline down to something more like 17% at the follow-up. And there was a decrease in Cambridge as well, but it wasn't as steep. And if we click forward one, we should see the numerical results here. We advance the slide. So we did this as a difference in differences analysis. The reduction was about 14 percentage points in versus a reduction of 6 percentage points in Cambridge for a difference of 8. And while that's in the right direction, it was not statistically significant. So let's move on to the next slide. So here are the results for nicotine. This is always more dramatic when you can reveal one line at a time, but what we see here is that there was a very steep reduction in the proportion of apartments that had detectable nicotine from baseline to follow-up in Boston, in particular from 47% down to, I think it was about 12 or 13%. So that's a fairly significant reduction in airborne nicotine in folks' apartments. And that's great, but we see a similar reduction in Cambridge. And if this was behaving sort of the way that we would like to see, just in terms of study design, if not in terms of residents' health, the Cambridge line would have been flat. So it's a bit of a mystery as to what was going on in Cambridge that would depress nicotine levels there as well. We can say that there is a decrease in airborne nicotine that's associated with the BHA's policy, but we're not able to say with great certainty that that decrease was necessarily due to the policy itself. It may have been, but the evidence that we have here doesn't tell that story specifically. All right, next slide, please. Okay, so here are the actual difference in differences results, and not surprisingly, not a significant difference there. Next slide, please. And here's what happened with residents' cotinine. So that's individuals' exposure to secondhand smoke, and this is the one that had me up at night. We saw an increase in residents' cotinine from baseline to follow-up in Boston and a decrease in Cambridge. And if we can advance that to show the table, we can see that this is actually a statistically significant difference. So really unclear what's happening here. I mean, one thing I think that we can take as consolation to some extent is that the nicotine levels in the apartments were going down. And so this increase which we're seeing among Boston residents is not something which is taking place inside their apartments, presumably. So we then looked to some of our survey answers to see whether we could identify specific locations that might have explained why this change happened the way it did. So next slide, please. So first of all, we looked around doorways to residence buildings. That was our initial hypothesis, that maybe if the smokers were concentrated outside the doorways now, that would subvert the policy. And we don't see a clear story there based on the residents' self-reports of seeing smoking around and smelling smoking around the doorways. Next slide, please. We also asked if residents were smelling smoke at work or a place that they volunteered or a place they went to school, other places that they would spend significant amounts of time. We don't see that as the source of increased exposure for Boston residents. Next slide. We also asked about other public areas within residence buildings, so hallways, stairways, common areas, rec rooms. No significant difference there to explain what we're seeing. Next slide. And lastly, we looked at whether residents were being exposed in friends' homes outside of BHA properties or CHA properties, and we don't see that. We see a slight difference there, but it's not statistically significant and does not look particularly impressive or overwhelming. So we asked about a number of other locations as well. All of them tell very similar sorts of non-stories. So all of this ancillary data that we have doesn't quite explain why levels would have gone up in Boston relative to Cambridge among in residents' individual exposure. Next slide, please. So we also did some common area air quality measurements, and so this is in hallways and stairways and around doorways. In this case, we combined data from the fresh air study and from the pilot study that I mentioned earlier. So there were 10 BHA sites and 6 CHA buildings included in the sample. We did, again, 7-day measurements of both nicotine and PM 2.5. There were multiple nicotine monitors in each site. There were the PM monitors were both indoors and outdoors to try to, at least to some extent, control for ambient levels that would exist outside the buildings. And again, we adjust, given our initial results, we adjusted for season and within site clustering. So if we can advance the slide and one more. So these are regression results, but we can focus on the line with the box around it, since that is the sort of difference in difference estimate that we're interested in. And what we find is that for Boston, the change from before to after was more negative than it was for Cambridge. So that's what we're expecting to see, a negative sign on that particular measure. And the p-value there was 0.09, so it's not at the 0.05 that we like to see in research, but it's at least in the right direction. When we look at nicotine in the middle column there, again, we see a negative value that's close to statistically significant, although not quite at our standard level. And then we also wanted to look at whether there were changes in the sort of higher levels of tobacco smoke pollution in these spaces. So we did a percentile regression at measuring the 90th percentile, and again saw a negative change for that difference in differences, a little bit less significant in that situation. But I think the take-home here, even though we don't have statistically significant findings, is the consistency of these results suggests that the air quality in these public spaces was probably improving in association with the policy from before to after. Next slide, please. So we also asked about residents' experiences with the smoke-free rules, and the results that I'm reporting here are specifically for the residents of family housing. These were non-smokers. That's just sort of reminding us of the context. And we're only looking here for these results in the BHA and in the post-policy period to see about what the effects of the policy are. Obviously, only in the post-policy period and only in the BHA was there a smoke-free rule. So 91% of our BHA respondents said that they were aware of the smoke-free policy, so that's good. The word got out. 87% said that they were satisfied with the policy rollout. Most believe that the policy is fair. Many of them supported stiff penalties for violations of this policy, although when we asked whether eviction should be a potential penalty, that was kind of where folks drew the line. They were not in favor of that as a penalty for violating the rule. Very importantly, about 51% of our respondents indicated that it was their assessment that residents rarely followed the smoke-free rule. So based on their self-reports, they were not seeing, they thought that people were not complying with the rule. There was also low dissatisfaction with the enforcement of the policy, and we used a composite measure of residents' overall housing satisfaction that was assessed elsewhere in the survey, so these items were not assessed at the same time, and what we found was that the satisfaction with the enforcement was negatively associated or was associated with housing satisfaction. So if you were less satisfied with the enforcement, you were also less satisfied with your housing in general. Next slide, please. So in addition to the fresh air study, one of my colleagues at the Harvard School of Public Health, Inez Adams, she's a postdoctoral fellow there, has been doing some work in elderly and disabled housing in the BHA, and she's been doing one-on-one semi-structured interviews with residents. So she was conducting those interviews in English, that's her native language. She did opportunistic sampling, and she recruited 30 smokers and 30 non-smokers to participate in these interviews, and also did some direct observations of what things look like in these housing settings. Next slide, please. And so findings that she made from these interviews included that there were improvements associated with the policy. So residents reported smelling smoke less in the common areas. The common areas were cleaner, fewer cigarette butts around. But at the same time, among the smokers that she interviewed, 23 of 30 admitted to smoking in their units as much or more than they did prior to the policy. And so, the assessment that she got from them was that, they felt like they needed to sort of hide out a bit more with their smoking, and therefore they were doing it within their apartments where it was less obvious. I guess folks, were not willing or able to go outside to do that. Again, this is the elderly and disabled housing and not the family housing that we've been discussing for most of this presentation, so it's a slightly different population. But that was certainly the case. A lot of folks were using indoor air purifiers to try to mask that smoking, although we all know that is not up to the task. Not surprisingly, the smokers resented the policy, and among the non-smokers that she interviewed, they indicated that secondhand smoke was not really their primary housing-related health concern. There were other things that they thought were more important for the Housing Authority to address than secondhand smoke. They weren't against the policy, but they just didn't think that it was necessarily the highest priority. They were empathetic about smokers' health, so they were, they wanted something which was going to be helpful to their smoking neighbors, but they were also sympathetic to the inconvenience that the policy caused to their neighbors. Again, this is in the elderly and disabled, and the responses might be significantly different on those two counts in family housing. Okay, next slide, please. So to summarize, in our cross-sectional studies, the pilot work, it looks like the smoke-free policies are associated with reduced secondhand smoke levels. So that certainly suggests that these policies are potentially effective. And notably, the smoke-free sites for those studies were voluntarily smoke-free. Then from the fresh air studies, we saw that there was a reduction in nicotine levels in the apartments, so that was good news, but it wasn't clear necessarily that that was policy related, though we do see that there is a reduction in common area secondhand smoke according to those air quality measures. Residents' secondhand smoke exposure did increase in Boston relative to Cambridge for reasons that we've not been able to really pin down. It's not due to any identified exposure in the BHA. Certainly the in-unit levels went down, so it doesn't appear that that was the source. It could be that these are just sort of really low levels of exposure and there's some kind of regression to the mean that we're seeing over time that's causing these differences. There may have been small changes in public area exposures that were not noticed by residents. So, I think that there's really is sort of unclear kind of what was driving that particular result. Next slide, please. In terms of resident experience, the non-smokers like the policy, although they think the enforcement is lacking. The smokers don't like the policy, and many are not complying with the policy. One thing that I want to really emphasize here is the BHA, as Brian indicated, was really at the forefront of this effort. And so they were sort of figuring this out as they went along, and the results that we have are from the period in the immediate aftermath of the smoke-free rule. And we've not been able to go back and we've not had the resources to go back and do measurements since these studies were completed. So it is quite possible that the picture is significantly different now than it was initially. The BHA's implementation has been improving and evolving over time. They now have email and phone hotlines for complaints so that people can make anonymous complaints about any smoking that they're observing happening in their buildings. And the sort of adjudication process of complaints and the procedures for dealing with, I want to say prosecuting, although that's too strong a word, violations within by residents is now being sped up a bit to facilitate enforcement. All right, next slide, please. So there are a number of unanswered questions here. One really important one is what's going to happen to smoking rates in public housing authorities. So, the rationale for the rules is, generally speaking, to protect non-smokers from the smoke in their environments. However, we know that restricting the availability of places to smoke will depress smoking rates, and that might actually be, from a public health perspective, the greatest benefit that we see from this policy is if smokers abandon the habit because it's just too much of a pain to keep going with. We don't have a really clear picture of what's going to happen in the elderly and disabled housing. We have that interview data, but we don't have a much more comprehensive data. We did not measure what any of the effects might be on children's exposure. We don't know what the effects are going to be on third-hand smoke, so the tobacco residues that are left on surfaces. Those are absent some kind of additional efforts to clean up residences are likely to persist for a long time. And, we know that there's a strong connection between secondhand smoke exposure and health, but we haven't actually measured what the relationship between the policy is and ultimately residents' health. So these are all, I think, important questions that can be pursued going forward. Next slide. So just challenges that I think housing authorities are going to have to be cognizant of as they consider implementing smoke-free rules if and when the HUD policy becomes national, are going to be supporting smokers. You know, they will need to be. I think it's going to be really important to have smoking cessation services available to residents who are interested in taking advantage of those. That was present in Boston, but they were very poorly attended, and I know the same was true in Cambridge, which is now also smoke-free. And I think it's also going to be important to provide smokers with a safe place to smoke. Many housing authorities, particularly in urban areas, might not be in tremendously safe neighborhoods. A lot of people don't feel comfortable going outside to smoke. In Boston in the wintertime, it's not very comfortable to do so. You know, providing folks with safe places to smoke will aid in their ability to comply with the policy. Enforcement and compliance is a huge issue in the HUD's proposed rule. One thing which was not quantified was what the cost of the recurring cost of enforcement would be. And we know from Boston's experience that, you know, you might have one building manager who's responsible for 2 full housing developments. Something might be happening in one place, and by the time the building manager gets there, that incident is long over. They can't catch the person who was responsible. So just being able to pursue the complaints and to monitor tobacco use in the developments takes a fair bit of resources. Right now there's some technology which is emerging to monitor nicotine in real time. There are monitors which are being developed which will be connected to Wi-Fi, which could then sort of notify a building manager of a smoking incident in a particular location. You know, it's not clear whether that's necessarily going to be an affordable mechanism to rely on for enforcement, but it's you know, it's something to keep an eye on as time goes on. So with that, next slide. I just want to wrap up by acknowledging a really large team of people who was helpful in this work. My colleagues at Mass General, Gary Adamkowitz at the Harvard School of Public Health and their Environmental Sciences Department did our air quality measurements. The Committee for Boston Public Housing is a resident advocacy group that was really instrumental in helping us liaison with residents and recruit for our study. The New England Research Institutes who did our field work, and our colleagues at the Boston and Cambridge housing authorities who were tremendously supportive, who were way out in front of a lot of housing authorities on these issues and have been working really hard on this issue to protect their residents' health. And then lastly, next slide, I need to thank my funders, so the National Institutes of Health, the Flight Attendants Medical Research Institute, and the Harvard School of Public Health. And with that, next slide, I will say thanks so much for the invitation, and if we have time for questions, I'm happy to answer some.
Well, Dr. Levy, thank you very much. This is Phil. Let me start by asking a couple of questions. On the elderly housing and disabled, what is it that they did find that they cared more about than the smoking policy? Did you learn something about that?
A little bit, yeah. And Inez took some, you know, really striking pictures. You know, there are air vents which are, you know, caked in years and years and years of dust and grease and who knows what else. You know, I think so that there are just some sort of structural, physical, plant kinds of issues that residents were concerned about. I know that Gary Adamkowitz has been working hard on things like integrated pest management within the BHA and other locations. So I think, you know, those are other issues which were regarded as important as well.
Right. Okay, that makes sense. And also, in terms of our noncompliance relative to other populations, is it a function of the fact that they are in fact elderly or disabled and can't be as mobile as easily? Is that something that you learned something about, or is that an assumption I'm making?
You know, we don't have the information to compare the elderly and disabled residents with the family residents on that particular question, but I think it's a reasonable assessment. And my understanding of, you know, so the BHA was very concerned initially that they might be overwhelmed with people making reasonable accommodation requests with respect to smoking. You know, I'm addicted, or my doctor says, you know, that if I stop smoking, that's going to exacerbate my mental health issues, et cetera. And the housing authority was very adamant, and I think rightly so, that those kinds of accommodations weren't going, you know, accommodations to allow smoking in apartments weren't going to be considered, but the accommodations which they have considered and acted upon has been moving residents who have mobility issues closer to doorways so that they can comply with the policy more easily. But obviously that's something which can be done on a small scale, but there's a limited number of units which are going to be easily accessible to the doorways, and so the ability to provide those kinds of accommodations is necessarily going to be limited.
Right, understood. Thank you for that. Are there any questions from those of you in the room for Dr. Levy? Melissa, would you ask and see if there's anyone on the phone with a question for Dr. Levy?
To ask a question, please press star 1. And we have a question from the line of Nate Burden.
Go ahead, Nate.
Yes, Dr. Levy. I had a couple of questions. One, for confounding factors, did you look at also, I know a lot of people wind up using candles, incense, and even marijuana as another issue for PM smoke and things like that. The second issue was a lot of the HVAC systems, are they central or are they individual units? And a lot of times if there was smoking going on and then they stopped, a lot of times the filters themselves will contain a lot of that particulate capture, and then when those systems come back on, they a lot of times can input PMs back into the living envelope. That's the first question.
So we didn't measure candles and incense specifically, or cooking events or things along those lines. I think our hope was that would be relatively similar between the two sites, although we did not measure that specifically. We asked about smoking generally. I don't think we specified cigarette smoking, so to the extent that marijuana smoking was going to be a part of that, and that people were going to be candid with us, although we obviously gave assurances that their responses would be held entirely confidential. We did control for that and don't see that that's a major factor. Again, these are households where we said that there should be, at the very least, no cigarette smokers, and so that's going to depress the number of marijuana smokers as well. In terms of ventilation, to be truthful, I don't know the answer to that, and I suspect that it probably varies to some extent from building to building, or development to development. I think, again, to the extent that we were doing measurements in the same units at baseline and again at follow-up, that in terms of we were looking at within unit differences, and so the differences that we do observe, I think, are going to adequately control for that kind of difference. But we don't have specific measures on that.
Okay. Yeah, the second question then would be, thank you for that answer. Second question, did you consider looking at, say, for those kind of housing units, a lot of times there are people with asthma, was there in the surrounding hospitals for a building that adopted this smoke-free environment, was there any view of looking at a reduction of asthma events that carried people to either medical attention or to a hospital, and to see if that, reduction of that secondhand smoke reduced the possibility of asthma attacks, or major critical ones?
Sure. So we didn't look at hospital data. We did ask residents who are our participants about asthma history and asthma symptoms, as well as general health. The general health measure is a fairly blunt measure of health status. We didn't see a change there. And the asthma measure is obviously going to be salient for a smaller proportion of our study participants, so we again didn't see a signal there. We did not look specifically at hospitals. I think especially in this context where, Boston has a huge number of hospitals,
Right.
just sort of even determining what the proper local institution would be difficult. Now, that being said, I'm trying to get some funding to do some work right now where we might actually be able to look at individuals' residents' healthcare use as a function of smoke-free policies. And so that's hopefully some work which we'll be able to be working on in the near future, but the results are way off for that.
All right. Thank you, Doctor.
Sure.
Okay.
And there's no further questions at this time.
Okay, no other questions. Very good. Well, Dr. Levy, you're welcome to stay on. If you have, it's perfectly fine. We're going to hear from one other presenter, but I want to thank you once again for joining us and for taking the time to not only prepare but deliver what was a very interesting topic for some of us here. We've been here in the Indoor Environments Division resurrecting our level of effort on secondhand smoke from what it was several years ago. So thank you very much for this.
Thank you so much for the invitation and for the very the great questions.
Okay, and the minutes for this meeting will, I expect, be posted to the website within days of the meeting's conclusion. So if we should get other questions, I can perhaps presume on your support in helping to answer them.
Of course, yeah.
Thank you. Okay.